Chapter 5. Doing Shared Decision-Making. Shared decision-making is more than loose clinical collaboration. It is a formal process of collaborative deliberation conducted by trained clinicians, supported by programmatic infrastructure to support the work. Hi, my name is Pat Deegan, and in this chapter we will explore how to do shared decision-making. Shared decision-making does not just happen by itself. Plans must be developed to support the routine practice of shared decision-making on teams working with young people with early psychosis. There are 4 things we must do to get prepared. First, we begin by communicating the expectation that individuals and their families or supporters will routinely be involved in shared decision-making. From day 1, individuals and family members should receive the message that they are part of the team. There is hope for recovery, and the team needs folks to speak up and share their expertise in order to arrive at the best decisions about treatment and recovery. Secondly, clinicians on the team must be trained in shared decision-making. Your team must have a plan to train new team members in shared decision-making, including the use of the Designated Observer Worksheet and the Ottawa Family Decision Guide. Third, it's important to put together a library of decision aids for easy access. Many decision aids are online and can be printed out. I suggest putting together a lending library for decision aids. Additionally, make a folder on your laptop or tablet with hyperlinks to the decision aids and recovery videos. Make index cards of web addresses of the recovery videos to give to families. They can watch them at home. And finally, make sure that in-consultation decision aids, such as issue cards, are placed in clinicians' offices for easy access. Fourth, be sure to talk about how shared decision-making can happen within your routine care pathway. Is there really time for shared decision-making in the medication consultation? Can that process be streamlined by people reviewing decision aids prior to the consultation? Make a list of common decision points encountered by the folks you work with. How does shared decision-making apply? How can shared decision-making happen in the field versus in the office? Should team members have tablets to make online content such as videos easily available in the field? With regard to the practice of shared decision-making, there are a number of practice models that overlap in significant ways. I am choosing to teach you a concise 3-step model developed by one of the world's foremost authorities on shared decision-making, Glyn Elwyn. As both an academic and a primary care physician who practices shared decision-making, Dr. Elwyn teaches us that there are 3 basic steps in doing shared decision-making: choice talk, option talk, and decision talk. These 3 steps happen within a context of collaborative deliberation that supports a person in moving from initial preferences to informed preferences. Step 1 in shared decision-making is choice talk. The goal of choice talk is making sure that people understand that choices exist. We don't want people making choices when they are insufficiently informed. The elements of choice talk include stepping back and making it clear to the individual and family that a decision needs to be made and there's more than one option to consider. An example might be, there is a decision to be made about treatment for psychosis. There are options to consider such as watchful waiting, cognitive behavioral therapy, or which, if any, medication to use. Next, we invite the individual and supporters to participate in making the decision. Don't be surprised if folks find this invitation unusual. If people are surprised, it can help to reassure them that one-size treatment does not fit all. There are pros and cons to each option, and some will matter more to individuals and families than others. Another great way to respond if folks act surprised is to say, I need you to help me to understand what's right for you. Now, sometimes people will protest and say, "But you are the expert. Tell me what to do." In such cases, it's important to defer disclosure, but not leave the person feeling abandoned or alone with a tough decision. Dr. Elwin suggests, "I'm happy to share my views and help you get to a good decision. But before I do so, I want to describe the options in more detail so you will understand what's at stake." Step 2 in shared decision-making is option talk. Whereas choice talk is about making sure people know that options exist, option talk refers to providing more information about the options. Of course, decision aids can be a big help during option talk. Continuing along with our example, one good way to begin option talk is to say, "What have you heard about treatment for psychosis?" This gets people talking and allows you to begin to hear their initial preferences and their misconceptions. The next step is to literally make a list of the options, including watchful waiting if relevant. Then turn the paper towards folks so they can see the list. Next, begin discussing the pros and cons, benefits and harms of each option. Continuing our example, we would discuss the benefits and harms associated with using antipsychotics, adjusting for gender, ethnicity, and age as much as possible. For watchful waiting and cognitive behavioral treatment, we would do the same. The last step in option talk is to teach back. Ask the person to verbally summarize what they have learned. Offer corrections as needed. Step 3 in shared decision-making is decision talk. Decision talk refers to supporting the work of considering preferences and deciding what's best. Remember that decision-making is not simply a rational process. Emotion is increasingly recognized as a critical component of human sense-making. Continuing with our example of choice of treatment for psychosis, knowing the facts of each option is not enough. Part of the work is affective forecasting, or asking oneself, what would the use of an antipsychotic be like for me? A good way to begin decision talk is to ask what, from your point of view, matters most as you consider these options. The role of the clinician in decision talk is to facilitate deliberation. Some questions that help are, what's the hardest thing about deciding? Given what we have discussed, do you have a preference about our next step? Are you ready to decide? Do you want more time? Do you have more questions? Are there more things we should discuss? Are there other people you might want to talk with to sort things through? Clinicians practicing shared decision-making must remember that deciding is a process and can take time. It might not happen in one consultation, and that's okay. People will often want to take information away from the clinic and share it with important people in their lives. This is called a distributed deliberation process and is not uncommon. In such cases, be sure to arrange a next visit with the individual so that you can review their thoughts and decisional leaning. Another strategy that can support the decision talk phase of shared decision-making is to use reflective listening techniques and say, given what you and your family have been saying so far, I might suggest blank. How does that sound to you? Finally, once a decision has been made, the decision must be implemented. As decision talk wanes, the conversation begins to focus on planning the next steps. Choice talk, option talk, and decision talk are the 3 steps in shared decision-making. You can find more tips and resources in your viewer's guide. This is Pat Deegan. Thanks for listening.